The last piece I threw in here is why this is a critical step, is that it begins to establish a sense of urgency. I've taken this from John Cotter's work from Harvard Business School called Leading Change, if folks know John Cotter. But his work primarily is focused around how do you lead change within a business organization. And I had the question of, well, why can't you use that to address leading change around disparities? And what I found was if you look through he has a series of 8 steps of what does it take to lead change, the first step he talks about is creating a sense of urgency. Why should somebody pay attention to this? And building the case, which ties back to the idea of securing buy-in. Okay, so let's talk a little bit about data collection and reporting. So this is some work from NPHHI survey just from 2006. And actually when I first saw this, I thought, wow, this is pretty interesting, and it's good that, you know, if you look at hospitals nationally that collect information on patient race, ethnicity, and language, that, you know, quite a few hospitals actually do this work, more than I actually thought. The challenging part is when you look at the next set of numbers and ask what do they actually do with it, that's the disappointing piece. And so I'm going to tie it a little bit into the reporting, because the reality is if you're already collecting this information, you need to begin to think about how do you analyze it, how do you structure it in a way to make your case, but also how do you use it to guide interventions and strategies that you want to do. Not just say that, yes, we collect race ethnicity data. Now, why is it sometimes a challenge? And I'm going to draw upon some of our experiences in Massachusetts, but it's also nationally that I've heard this, is that collecting race ethnicity data is sometimes illegal. Well, the reality is it's actually not illegal. Most institutions, and I haven't found a state that goes counter to this, but most institutions, most states will allow you to collect it either within certain guidelines or in a certain manner. There's also this idea that patients will be offended. We ran into this in Massachusetts, and what we found was if you actually educate the patient as to why you're collecting the information, and where a lot of pushback came back, if you educate the frontline staff, the administrators that Dr. Ayala mentioned, if you educate them as to why you're collecting this information, it goes a long way for helping them to understand. And I'll talk about this, how it played out in Boston in particular, but these were the 2 main things that we ran up against. So we had developed a number of different trainings for all the Massachusetts hospitals to collect race ethnicity data. So once you actually collect it, then as I mentioned, it's important to think about how do you analyze it, how do you stratify it by race ethnicity, and then how do you begin to develop a reporting mechanism to track and report disparities. And this is where it gets a little dicey, because whenever folks have to start reporting data, folks get a little jittery, okay? And it's from all kinds of different reasons, but it's important, going back to the point of accountability, that this is something that institutions think about reporting so that they can be accountable to the general public. So I know in New York there was a big movement to actually start to report quality data. And as one of my colleagues sent me the email, I'm sorry? 10 hospitals, yeah.
No, 10. You wanted me to...
Oh, 10 minutes. Oh, thank you. Thanks. I thought you were adding to this. Your got it. Thank you. Thanks. But as one of my colleagues emailed me and said, wouldn't this be great if not only did they report on quality data, but they reported on disparities data? Again, a great way for accountability, great way to kind of be very transparent about it. And as an example, if those of you are interested, is Mass General actually developed a disparities dashboard and a series of sort of key indicators to look at how they're doing in terms of disparities. I think it's reported every 6 months to a year, and it's very transparent and it's public. I won't spend a lot of time on this. This talks more about our dashboard. Again, just helping the hospital think about race ethnicity data. It gives a snapshot of the diversity of the patients. And they look at different things like wait times for appointments, communication with LEP patients, key clinical quality indicators, some of the HEDIS measures, patient experiences. But the takeaway message in particular that I wanted to share was that this was a highly, highly political issue. Again, once you start getting into reporting data, publicly reporting data, you've got to get leadership at the highest level behind this. And we are very lucky at Mass General that Peter Slavin is a huge supporter of addressing disparities, and he, as well as several of the board members, really got behind this, and it helped to sort of advance this. But it's one of those things where you sort of say, like a TV advertiser, be careful, don't do this at home. It's challenging to do, but not impossible. But it does require an enormous amount of leadership support to back you up. All right. So when you're moving to the point now of developing interventions, sort of taking the model, looking at action locally. As I mentioned, the key piece is collecting race ethnicity data, stratifying it by race ethnicity, or collecting data, stratifying by race ethnicity, looking for what disparities exist, and as Dr. Ayala mentioned, you don't want to look for just sort of are certain people of color doing worse, but you want to see if there's even reverse disparities that exist and begin to understand why that may occur, because I've seen that in a number of communities also. And then the piece that I want to encourage you to think about is starting to do some kind of either small group, I don't want to call it research, but looking into why those potential causes of those disparities exist. And they can be as simple as small focus groups with folks within small communities and say, you know, we noticed that in this particular area that there's an issue around infant mortality. You know, tell me a little bit about what's happening. How is it seen upon with children being born in this community? What's the thought or the approach around breastfeeding, et cetera, et cetera. So even if it's from that standpoint, or if you use the example of Seattle Children's where you could have a more rigorous research study looking at things like limited English proficiency and hospital error rate, but somehow beginning to explore and dig deeper into what are some of the potential causes as to why that's happening, and then developing some of your interventions. Okay. As I mentioned, this, as a quick reminder, we do this kind of work also over a year, because what we found in trying to get people to move from talk to action is that one of the greatest powers of moving groups and organizations together is peer-to-peer learning. And what we found is that there were folks that were doing great stuff like yourselves, but nobody was talking to anybody else. And when you bring them together to sort of share, it's this accelerated learning that starts to happen. So we had this program now for 2 years where we bring folks together to look at specific disparity intervention projects, and through the peer-to-peer learning, conference calls, web seminars, et cetera, try to help them to advance that work and accelerate that work. All right. The other approaches, which I won't spend much time on, which also came out of the strategy forum, was this idea of using reimbursement, specifically pay for performance. Is there a way to use pay for performance to address disparities? I know there are a number of folks that are looking at it. Not getting a whole lot of traction yet, but more so, more attention is being paid to see if pay for performance actually makes disparities worse. But this is another area that was brought up. The idea of public reporting around accountability. Can we develop dashboards that folks can see how different institutions, how communities are doing around disparities? Some kind of awards program. I believe NCQA has actually started this, where similar to like a Baldrige or one of these kinds of awards, to award people for the efforts and the improvements they've had in addressing disparities. And then exploring different actions by payers, and this is an ongoing thing that several of us are involved with, and trying to think about what role the payers can play in trying to address disparities. And then the idea of a media strategy, because if you look at some of the numbers, most people in the United States, I believe it's only 56% of the people in the United States even know what health disparities are. So if you look at it from the context of generating public will, people have to know about it before they can actually get behind it. So there's this idea of, is there a way to use media strategy to both raise the awareness of this issue and get it on the agenda